Now we are being recorded. Hello, everybody. Before we start, we want to thank Dr. Chuquilin for coming in today and joining us to help us get a better understanding of not only drugs that can help patients with treatment of periodic paralysis, but also some questions regarding other drugs that may be safe or unsafe for patients with periodic paralysis. And before I hand it over to him, I just want to let everybody know that this is being recorded. It is going to be on our YouTube channel. So if you don't take notes fast enough, no worries. You'll be able to go to the YouTube channel, pull it up. It may take about a week for us to post it, but it will be on our YouTube channel. Also, we ask that if you have any questions, to unmute when the opportunity, he's going to speak. And he's going to do a presentation, and then we're going to allow questions. And at that time, you can unmute yourself and start asking your questions. If you do send it in, make sure you send it through the chat and not through email. But we do have some questions that were sent in beforehand that we will get to at some point during the webinar. And we ask that you limit your question, if you do unmute yourself, that you limit your question to 1 minute so that we can get in as many questions as possible. And I think I've got everything, so I'm going to go ahead and hand it over to you. And let me see. Let me find you now because it puts you in with everyone else. All right.
All right, so can you see my screen with a mouse moving? Yes, I think so. Oh, you're muted, Monica. I guess you muted yourself. That's good. All right, so thank you, Monica and the PPA and Sienna for inviting me to talk about periodic paralysis medications and treatment today. Just have about 25, 27 slides to go through, so and then we can focus on the questions. I think because I'm the host, I have to also monitor who gets in. Hopefully, I guess there is some notification coming in so I can let people into the meeting. Actually, wait, there is Monica. There are 11, I guess, people waiting to be admitted. Should I just admit all of them? Are you there? I guess.
She says yes.
Perfect. All right, so we can start. So we're going to talk about periodic paralysis and treatment. I have no disclosures relevant to this presentation today. So I have a few slides about periodic paralysis. Probably most of you are already very familiar with it. I just go through it really, briefly. So periodic paralysis are a group of autosomal dominant disorders. That means usually they run in families, and you just need one copy of the bad gene to be affected. And your, the children of the affected patient will have a 50% chance of inheriting the disease. There are a group of something we call channelopathies, meaning they're secondary to mutations in different channels. Usually the most common is going to be calcium, sodium, and also some of the potassium channels. They are triggered by, they're triggered by different, situations like fasting or exercise or eating potassium-rich foods or too many carbs, depending on the condition you have. And we'll go through some of the triggers lately. And then they usually will cause episodes of paralysis, which can be generalized or just focalized as well. So not necessarily the whole body needs to be affected. And these are the most common forms. Hypokalemic is the most common. Frequency is about 1 over 100,000 people. Hyperkalemic, 1 over 200,000 people. There is Andersen-Tawil syndrome, 1 in a million, and there is also thyrotoxic periodic paralysis, which is less common, but actually less common in the US, but relatively common in Asia. And this is just a little picture taken from one of Dr. Cannon's papers about channelopathies. So like I mentioned, periodic paralysis are a group of genetic conditions secondary to mutations in different ion channels. So these are the ones that are pointed with arrows here, we're going to talk about today. But channelopathies also cause myotonia. which is a medical term that describes delayed muscle relaxation or persistent muscle contraction after activity. And these are other channelopathies as well, including paramyotonia. And hyperkalemic periodic paralysis, for example, can also have some myotonia with it. So hypokalemic periodic paralysis, like I said, is the most common one. Usually patients are going to present with potassium very low and the lower limit of normal. And, you know, in people, it's usually 3.5 to like 5 or 5.5. So people with hypo-PP are going to have potassium lower than that. And this will depend on their normal baseline potassium level, really. A drop from the baseline can also trigger an attack. The first attack usually occurs in the first to third decade of life. And the paralysis can last hours to days. So this can be more dramatic than hyperkalemic periodic paralysis, but usually they last at least 2 hours. And periodic paralysis patients not only have paralysis, but also progressive muscle weakness, 50, 70%, depending on the series. If you follow them for a long time, they're gonna have some degree of muscle weakness that I guess the doctors think is secondary to the frequency of the attacks or the number of attacks you have throughout your lifetime, but that hasn't been proven, so that's a hypothesis. And usually hypo-PP patients don't have stiffness or myotonia, so they just have the paralysis, the weakness. And these are some of the triggers for these patients: carbohydrates-rich meals, so a lot of carbs, like bread, rice, things like that. Beer, alcohol can also trigger it. And rest after exercise and stress. And carbohydrates will trigger an attack because it increases the production of insulin, the hormone that controls the sugar in our bodies. And insulin will also promote the movement of potassium inside the muscle and tissue. So really can lower the potassium. In most people, that doesn't cause a problem because we don't have hypo-PP, but patients that are affected by this condition, if you drop the potassium just a little bit from the baseline, may trigger an attack. Hyper-PP, usually potassium is going to be above 4.5, or sometimes it could be normal, but again, usually you correlate that with the baseline potassium is going to be high from the baseline. Half of them have attacks during the first decade of life, so very similar to hypo-PP. And these attacks usually begin in the morning after fasting, and it can last up to 2 hours. So the duration is usually shorter, but they can happen more often than hypo-PP. And the difference from hypo-PP, usually these patients, up to half of them, 50% of them, will have myotonia or something called paramyotonia. So myotonia is this delayed muscle relaxation. They try to do the activities, and the muscle is stiff when they try to initiate the activity. And paramyotonia is the opposite. The more activity they do, the more stiff the muscle gets and more contraction they have. So they can be, very disabling symptoms depending on the activity they're supposed to do. They can also develop permanent muscle weakness later in life, about 40 or 50 or 60 years of age. And triggers, carbs actually help in this condition because, again, lower the potassium with the insulin effect. But they eat a lot of potassium-rich foods. They can trigger an attack. Rest after exercise as well. Fasting, cold can trigger myotonia as well. And stress and pregnancy. ATS, Anderson-Towel syndrome. The typical syndrome is a triad of 3 things, periodic paralysis, which is the weakness, cardiac abnormalities or EKG abnormalities, and some distinctive phenotype, which is the body appearance of the person, like the ears may be a little lower than usual, the eyes may be too close on the face, and the jaw may be small. They may have a little arching of the little finger. It's called clinodactyly. The toes may be joined together. It's called syndactyly. They may have scoliosis, a broad forehead, and all the different features that can be very subtle and very hard to distinguish. But then when you go in retrospect after making the diagnosis, you say, oh, actually, yeah, this was very clear. So sometimes people are undiagnosed with this condition. Symptoms usually start in the first or second decade of life, usually cardiac symptoms of weakness. But again, not everybody has the full triad. So you may have just a flaccid weakness and nobody had an EKG done on you, then you may actually have Anderson-Towil and not just hypo-PP, normal hypo-PP. And the potassium is usually low, but it can also be high or normal in these patients, and they can also develop progressive weakness. And the less common, the most rare, and usually more common in Asian population is the thyrotoxic periodic paralysis, secondary to this mutation in this potassium channel. And it can resemble hypo-PP, and it's actually the most common cause of hypo-PP in Asians and Hispanics. Usually affects males, and it can be triggered by thyroid supplements use also to lose weight, for example. Some people use thyroid hormone to lose weight because it increases your metabolism, or some of these weight loss supplements have, not undisclosed thyroid hormone actually, and then that may trigger your also thyrotoxic periodic paralysis attack if you have a mutation on this gene. So, okay, now going back to the treatment, or going into the treatment of periodic paralysis. So there are three phases of the treatment, or three parts that we need to take into account when we treat patients with periodic paralysis. One is education about triggers. The other one is potassium therapy, which is, either you need more potassium or less potassium, and then medications. About triggers, I already mentioned some of them. For hypo-PP will be carbohydrates, rich meals, because of the effect of insulin, increased insulin, and subsequent decrease in the potassium levels in blood. Alcohol, because also has a lot of carbohydrates, glucose in it. Rest after exercise. The mechanism for this is unclear, really. It may have to do with changes in pH and also potassium levels after exercise. It has to be usually after a few minutes of exercise, 10, 20, 30 minutes. Stress, supposedly from adrenaline release. Adrenaline can also affect the pH and trigger attacks of either hyper-PP. Pregnancy, hormonal changes, and also not clear hormones, how much they affect, hypo-PP, but obviously the volume, the blood volume is increased, and that may also contribute to the effects of periodic paralysis. Cold, usually more with hyperkalemic periodic paralysis. Sorry, I keep admitting people to the meeting. But it can also trigger hypo-PP. And cold, depends on the mutation you have, especially on hyperkalemic periodic paralysis, can trigger an attack because the mutations make your channels sensitive or less sensitive to potassium or sodium, depending on the temperature you're exposed to. And hyper-PP, potassium-rich foods, for obvious reasons, you eat more potassium, you're going to have an attack. And then fasting. Fasting triggers release of, adrenaline and also potassium in blood after 8 to 10 hours of fasting. So that can also be a trigger. These are some of potassium-rich foods. So I was preparing this slide and I was looking in the bananas, but actually the ones I highlighted here, from what I found online, have more potassium than bananas. So potatoes, sweet potatoes, and all these beans and legumes have way more potassium than just one banana. So almost double or triple the amount of potassium. But, these are some of the foods that maybe you have hyper-PP, you may try to avoid or minimize. You may not have to avoid all of them, but try to minimize the consumption of these. Regarding potassium supplements, so this applies to people with hypo-PP, right? You want to have some prophylactic therapy. You want to use some extra potassium to keep your potassium, close to baseline, maybe a little elevated from your baseline to prevent an attack. The different, drugs that you can use, of formulations of potassium supplements you can use. FRK is one of them, which is dissolvable, effervescent potassium, usually potassium bicarbonate. Also, chloroquine is something similar, just a different brand. There's also potassium chloride that is supposed to be the best absorbed. You use that, it has best absorption, but people may not tolerate that. It may also work on correcting the acidosis. Like if you, which we're going to talk about in other slides, use Diamox, acetazolamide, or Kebeyis, that may lead to acidosis, and potassium chloride may help because the chloride can counteract the acidosis on it. Along with bicarbonate as well can do the same thing. Potassium gluconate, potassium citrate, they're all very similar. You know, some people prefer one versus the other, maybe because of taste, of the effect they feel on their bodies. So there's, well, obviously there hasn't been any trial comparing one versus the other, and I think at the end they're all very similar. What is clear though is that you use a dissolvable formulation, not a tablet, but something that dissolves in water or liquid formulation works faster. So you may want to use that, especially if you're gonna use it as prophylactic agent before doing some exercise, for example, or something that may trigger the attack. You know, is going to trigger it. They may want to drink 30 minutes to 1 hour before as prophylactic agent. So that would be a good idea. And if you have frequent morning attacks, then the sustained release tablets may be better because, you know, the effect may last a little longer overnight, and then you may not have an attack in the morning. And if you have a dissolvable formulation, you know, dissolve in at least 4 ounces of water for every 20 milliequivalents. And ideally not use more than 100 milliequivalents per day on these supplements. Medications now, so potassium supplements are one part of the treatment. Medications, again, this will depend which one you use on the type of periodic paralysis you have. But the most commonly used, obviously, are the carbonic anhydrase inhibitors. The most well-known is acetazolamide or the Diamox. It's class C in pregnancy, so usually avoided in pregnancy as well, unless it's absolutely necessary to use. Diclofenac, Kevagis, not a lot of data in pregnancy, so prefer to avoid as well, if possible. Other medications like antiepileptics, really, but I also have carbonic anhydrase activity, inhibition activity, so act kind of similar mechanism to acetazolamide and Kevagis, topiramate and sonizumab, but they're antiepileptics, so they absolutely should be avoided in pregnancy as well. Now, what is the action mechanism in periodic paralysis? This is not known, but there's some hypotheses, especially, for example, if you have, you know, hyper PP, maybe, you know, because these are really a water pill, acetazolamide is a water pill. So maybe you're excreting more potassium in urine, so maybe helping because you're decreasing your total potassium in your blood or in your body. And also promotion of acidosis, so changing in the blood pH that may also help with especially hypo-PP, but also hyper-PP patients. Now there is some, I guess, warning in the prescription package of acetazolamide and Kevagis about sulfa allergies. When I look more into it, I guess the experts on allergies, they don't feel as a strong warning. I mean, you know, if there's a medication that's actually helping you think may help, and you're really affected by the weakness, you could still try it. And because the chances of having a cross reaction with a sulfa antibiotic are low, but it's not 0%, but it's low. What are the side effects of these medications? So acetazolamide, diclofenac, and either really topiramate and sonizumab as well. Paresthesia, so this is tingling, you know, pins and needle sensation around the lips, the fingers, and the toes. This can happen very often, actually more than half of the patients, depending on the trials, but 50–70% of people can have that. So it can be very annoying to some people, and the best way of dealing with it is decreasing the dose and trying to re-challenge again. Some people get used to it. Fatigue, which is just mild, you know, feeling tired. Cognitive problems, fogginess, you know, inability to concentrate, confusion. There can be maybe 20–30% of people, depending. And kidney stones. So some people can develop kidney stones even if they didn't have one. It's not a lot of people though, depending on the trials. And I have another slide about this. There's like 2% to 20%, and some of them already have kidney stones before starting the medication anyway. So I usually advise patients that take these medications to drink a lot of water and avoid soda, you know, caffeine that may actually worsen kidney stones as well. So there are some papers, and there are 2 papers here I found regarding this res different response to acetazolamide depending on the mutation they have or the gene that's affected. So there are some reports of acetazolamide to Diamox causing worsening of hypo-PP in patients with sodium channel mutations. So this is a sodium channel SCM4A. Some case reports mention that. And also this paper by Matthews in 2011 mentioned that about 50% of patients, or 74 hypo-PP patients responded to acetazolamide, but most of the response was seen in patients with calcium channel mutations, not with the sodium channel mutations. So that's something to consider when we're prescribing these medications. If there is not a good response, if the patient has a sodium channel mutation, maybe it's worth changing medications to a different strategy, because it may not be. And this depends actually on the type of mutation they have in the sodium channel as well. But something to consider. There have been 4 clinical trials and about 3 to 4, actually 4 papers, or maybe more, about diclofenac, which is the FDA-approved medications for periodic paralysis. It's also a carbonic anhydrase inhibitor. It's many times more potent than Diamox. So I found that it's 30 times more potent in vitro than Diamox and 5 times more potent in vivo. So we can adjust the dose by dividing by 20%. So you take 1,000 milligrams of Diamox, then the maximum dose for diclofenac would be 200 milligrams. So it depends on what dose of Diamox they can switch to Kebeyis if needed. So in these 4 trials, they included hypo-PP, hyper-PP patients. This is the number of patients, 70 patients. And they gave them medication for 9 weeks, then compared with placebo, and then they crossed over. So all the placebo patients went to the active medication. And there was a reduction of attack rate and attack severity, and mostly in hypo-PP patients, but hyper-PP patients also had some improvement, especially in follow-up and long-term after more than a year. And this is the percentage of side effects, I guess, reported in people using diclofenac. Paresthesias, cognitive problems, like I mentioned before, dysgeusia, which is, change in taste, like the soda may taste flat, and just maybe some bad taste in the mouth, a metallic taste. Kidney stones, 3 to 20%, and this is the dose that is usually recommended, 50 milligrams twice a day, starting dose, and you can go up to 200 milligrams a day. Now going by to specific management per condition, in hypo-PP patients, one thing to remember is that there is not a net deficit of potassium. So it's not like the patient has lost potassium, well, unless they have diarrhea and other things that may trigger also the attack. But usually there's not a deficit. It's just a redistribution of the potassium. The potassium usually gets inside the tissues, like the muscle, for example. And so your potassium in blood is low, but total potassium in the body is unchanged. So acute treatment, mild exercise may help. So many patients feel when the attack is coming, they feel an uncomfortable sensation, and they start feeling some pain in the muscles, some tingling in the muscles or in the legs. So they know, okay, my attack is coming. Walking around the room, shaking the arms, stretching the legs or the arms may help stop the attack or make it a little milder. And the mechanism for that, again, is not clear, but exercise really increases potassium locally around the muscle. So maybe that's the mechanism why it will help. And then, well, it doesn't work, then you also obviously have to take potassium. In this case, remember, there's not a deficit in potassium, so we don't need to overshoot the mark. We just need to, keep it close to the baseline for the patient. Oral potassium is preferred, so they can take, oral potassium supplements every 30 minutes, maybe 10 to 20 milliequivalents every 30 minutes, and not to exceed up to 200 to 50 milliequivalents a day. Liquid potassium, like I say, works faster, so that's the preferred version of potassium. Using 40 to 60 milliequivalents may increase that level by 1 to 1.5 milliequivalents, so that's important to remember. So the patient is, already taking 60 milliequivalents and the potassium is still low, so may require IV replacement, but again, that needs to be monitored with EKG, because if you should above the desired value of potassium may cause arrhythmias and can be actually very concerning as well. But most patients will respond within half an hour of starting treatment with oral potassium, and then you start noticing, reflexes coming back, the strength is improving, and then, well, the patient just feels better. If we are using IV formulation of potassium, it has to be dissolved in something called mannitol, which basically we're trying to avoid saline, so salt, and also glucose, because that may actually make the symptoms worse. So mannitol doesn't have that problem. How do we prevent attacks, though? Again, avoiding carbohydrates or a lot of salt in the diet, because that can be a trigger. Avoid some of the other triggers that I mentioned, alcohol, stress, and can also use daily potassium supplements, 30 to 60 milligrams a day, or the slow release form of potassium that may also help to keep the potassium at a level that is appropriate for each patient. Now, some patients don't get a good control. They still have some attacks, even with oral potassium supplements, every day with prophylactic treatments. So they need some other extra medications to help. So the carbonic anhydrase inhibitors are one option, either acetazolamide or diclofenamide. There are some papers, mostly case reports, that mention that even patients that have some weakness after many years of periodic paralysis, after using medication, can improve the muscle strength level. They follow up MRI after I think a year or 2 years of treatment, and they notice an improvement in muscle mass and muscle signal. So that's possible, that some of the changes could be reversible with treatment. Some patients don't tolerate the carbonic anhydrase medications, though, because of the side effects. Maybe they have too many kidney stones. They cannot take it. They can handle the tingling. They can handle the cognitive problems. They become slow, and they're very active people, so they don't like that. So in a hypo-PP, we have the option of using other water pills, basically diuretics as water pills that make the body retain potassium. So instead of the potassium being loss in the urine, like usually is, to keep a balance, these medications make the kidneys retain more potassium than usual. And so it will elevate your potassium level. But again, we don't want to go above the level we want. So in these cases, we have to check the potassium, maybe every 2 to 4 weeks. And then once we know there's a stable dose, we can follow every 1 to 3 months. Because we don't want to cause hyperkalemia or high potassium levels either. So eplerenone is one of the medications I guess we can use for that. Androgenic means, excessive effects, which can cause some gynecomastia. Gynecomastia is like developing of breast tissue, excessive breast tissue in males, for example. So that's a obvious side effect that males don't want. So spironolactone is not preferred for that reason. So eplerenone has less of that effect. So that's an option. Tramtidine is, I don't think it's commonly used. Personally, I would probably use more eplerenone than tramtidine, but obviously using the potassium monitoring. Now, talking about hyper-PP management and acute crisis, mild exercise may also help. Okay, so moving around, standing up and shaking the arms and the legs if you feel the attack is coming may also be helpful. Carbohydrate snacks, so it's recommended that patients that have hyper-PP carry some snacks, chocolate bars, candy, the purse and the pocket. So if they feel the attack is coming, they can eat that, and that can also decrease the potassium levels. Insulin gets released, and then potassium level goes down, and then maybe the attack is aborted. And beta agonists, salbutamol, albuterol puffs, so that the inhalers that people use for asthma can also be helpful because they increase the adrenaline level. This has to, I guess the patient has to be trained to use the inhalers, because some patients don't find relief from the inhalers. I think it's because they don't know how to inhale it and get it all the way down to the lungs. Some of the prevention for hyperkalemic periodic paralysis, again, carbohydrate snacks and multiple carb meals, avoiding potassium-rich foods, avoiding some of the other triggers I mentioned before. And carbonic anhydrase medications also work here. So diclofenamide, acetazolamide, they also work. So they work for both. They work for hypo-PP and hyper-PP. Now, other water pill that we can use is thiazides. One of them is called hydrochlorothiazide. So this one is a medication that will promote potassium loss in the urine. So you want to lose more potassium because, you know, high potassium is harmful to you. So you lose potassium taking more water pills. And you want to avoid the water pills that make you retain potassium. So the spironolactone, the eplerenone, you cannot use that. Instead, you use the water pills that promote potassium release in the urine. For Andersen-Tawil syndrome, the acute attack, again, people can prevent or make it a little less severe with mild exercise. And most patients are going to have low potassium level during the attack, so you're going to give them a potassium supplement, either oral or IV. Oral is preferable. And if they have high potassium, then carbohydrates are a good choice. And this management has to be done with monitoring EKG and serum potassium. Acetazolamide, diclofenamide are also helpful for this patient group. In these patients, we're going to avoid salbutamol because it can make arrhythmias worse because of the adrenaline. So it can cause more tachycardia, and they may already have some EKG abnormalities. So that may be a little dangerous, actually. And also avoid the water pill that makes you lose potassium, because if you drop the potassium too much, they may also worsen the EKG changes. These patients recommended that get some periodic EKG follow-up, or something called a Holter monitor, which is a monitor of an EKG for 24 hours or even sometimes many days to look for any dangerous arrhythmias. This is more cardiology management, but some antiarrhythmics that are helpful are flecainide and some of the beta blockers, calcium channel blockers, and depending on the type of arrhythmia patients have. For thyrotoxic periodic paralysis management, remember these patients almost always have hypo-PP or hypokalemic form, so they have low potassium, so they need potassium supplementation. Because of the thyrotoxic state, so high thyroid hormone, they have a lot of sympathetic activity, so a lot of adrenaline activity in their body, so they need beta blockers, which is basically a sympathetic blocker to control the arrhythmias and tachycardia and the thyroid function. And then also the thyroid medications, iodine or anti-thyroid medications. And then once the thyroid is controlled, then really the attack stops. Now, this is, I think, the last slide I have. So I focus on mostly on the periodic paralysis management part, but as I mentioned before, some of the channelopathies, for example, hyperkalemic periodic paralysis, also have myotonia, which is this persistent muscle contraction. And myotonia is basically caused by an abnormal activity of something called the sodium channels. So they have more activity than usual or repetitive activity, and your muscle keeps contracting when you're not supposed to. You're supposed to be relaxed. So the treatment in those cases, when the myotonia is uncomfortable or disturbing to the patients, is using some sodium channel blockers. These are some of the commonly used. Most commonly used is going to be mexiletine. This needs to have some EKG or cardiology clearance to use because it may trigger some ventricular problems too, but it's usually well tolerated. Lamotrigine is a seizure medication, but also has some sodium channel blocking properties we can use to control myotonia. Ranolazine is used for cardiac or ischemic angina, but it's also a sodium channel blocker, and flecainide is an antiarrhythmic. So these are for the most commonly used options. Other sodium channel blockers are antiepileptics like carbamazepine, phenytoin. Those can also be used. And that was all I had for you today. Thank you. I don't think I didn't forget to admit anyone. So now I'm gonna stop sharing, I guess, and I'm gonna let I don't know, chat. Oh, there's someone waiting for me. Okay, I just admitted. So, Monica, you're gonna be the host now, or how do I do this? Yes, okay. So let me find you here, I guess. How do I do this? Make host. There we go. Okay. So I made you a host.
Oh, perfect. And we make sure that everyone can unmute themselves if needed. So before we start reading, thank you so much. That is very important information, especially about the pH levels. You know, that's one of the things that we tried to really start educating patients on this year was those pH levels, because sometimes it's frustrating as a patient because you feel like you're doing everything, right? You're eating right, you're taking your medication, you're limiting your stress, but you still can't seem to have a normal day. And now that we know that we have to be aware of our pH, that alone can trigger an episode, that's very helpful information. So thank you again very much. So before we take a question from the people who are here tonight, I wanted to start with a question from a gentleman from Western Australia. His name is Bruce. He has two questions, and I think you might have answered one of these, which is, what is the place today for using potassium channel openers in treating the permanent muscle weakness for hypo-PP? And that's the Diamox. Oh, oh, let me see.
Okay.
There we go. Sorry.
No, Diamox is a carbonic anhydrase inhibitor. It's not a potassium channel opener. So they're not really a potassium channel openers that I'm aware of, at least that come to my mind. The mechanism on periodic paralysis, really at the end, is if you remember, most common is hypo-PP. Hypo-PP, the most common cause of hypo-PP is not in the potassium channel, it's a calcium channel mutation. And some of them are also sodium channel mutations. But how does that relate to the potassium? Well, the potassium is the ion that actually stabilizes it's responsible for a lot of the resting membrane potential in the muscle and also in the nerve and all the cells, really. So changes in, some of these other pH and the other calcium channel, the sodium channel, eventually will lead to abnormalities in the potassium concentration, or the potassium, the response of the muscle to the potassium. So there is not really potassium channel medication that is, I guess, available right now for use. As the medication usually focusing now on the sodium channels, like the Diamox, or some of the other myotonia medications, for example. And potassium channel mutations are usually from, for example, Alexander-Will syndrome or the thyrotoxic periodic paralysis, but the medications we use are very similar as the other conditions.
So one more question, and then we're going to go to Mary Ann's. Is there a PCO, and I'm hoping you understand what that is, a PCO currently being used worth considering? Oh, you're muted again. Why is that happening? Let me see really quick.
Okay, so I think I muted myself again, but I'm gonna stay unmuted then, so I don't have this problem. So I don't know what PCO is. I don't know PCO. So can you repeat the question again? Is there
a PCO currently being used worth considering? And I don't know if it's like maybe a primary care well, I don't know if it's because he is out of this country, so I don't know if it's an abbreviation
PCO?
for.
I don't know.
Okay.
potassium channel opener. It's probably the same thing. Probably that's what he's
Oh,
asking.
okay.
Yeah.
That's worth considering. And would that be Diamox or Kaveyis?
No, they're not potassium channel openers. No.
So is there one that is worth considering, or there isn't any potassium channel openers?
Not that I'm aware of. There may be some for cardiac use, but like once I look into their sodium channels, so not potassiums. Not the one that I'm aware of.
Okay, so let me get to Mary Ann here. Hold on a second.
So I have some of the chat here. You want me to read or
Well, I'm gonna unmute Mary Ann and she has a question.
Okay. First of all, thank you to the PPA and to Dr. Chuquilin for doing this tonight. I have hyperkalemic periodic paralysis, and which I passed on to my son before I was properly diagnosed. And we both have myotonia, but his myotonia is worse than mine. And he takes Vimpat for that. Vimpat has recently been changed to a generic. And he doesn't find it as effective as it was. Is there a reason for this? And what can he do about that?
Yeah, Vimpat is an anti-epileptic. Does he have seizures too? No.
No.
It's an anti-epileptic. It's also a sodium channel blocker.
Yeah.
Sodium channels are responsible for a lot of things, including nerve hyperexcitability, so prevent seizures, but also myotonia. Now, what you're saying is that generic Vimpat or lacosamide Vimpat is not as effective as brand lacosamide.
Yes.
Is that what you're saying?
Yes, as the brand name Vimpat.
Yeah, I mean, may have to do with maybe the quality control on the generic pills or the extra stuff. It's not just whole Vimpat in the tablet, right? It's excipients and the sugar part that gets added to the pill to make to make the whole pill. It's not pure Vimpat. It has some added stuff to make it a pill.
Yeah.
It's probably different. It's probably different in the generic versus the brand name. That's what that would be my suggestion. Maybe even the release, how much is released and absorbed. So someone will have to do a comparison with the specific pill your son is taking and the brand name and see how much is accumulated and released in the body.
You can't get the brand name anymore. His insurance company won't cover that, but he's still trying.
So I have a question though too, that I'm also hyper and I have severe myotonia. And what I have found that has helped me, and if Dr. Chuquilin can, let me know if this is correct to also be sharing. But I have had great success with just sodium bicarbonate. Now I have to be careful when I take it, and I can't take a large amount of it every single day or anything like that. But when I'm having really bad days of severe muscle stiffness, or if I'm having these things, like sometimes they look like seizures, the sodium bicarbonate helps. And to my understanding, it helps because it is helping the pH balance. So now I'm becoming less acidic. So I'm able to, my muscles are able to function. Is that an option possibly for her son, Dr. Chuquilin?
That could be an option, it's not commonly used, but yeah, changing pH, I mean, it will be interesting if he tries that, he finds it beneficial to have, I guess his ABG or his pH measure before and after taking it and see that's actually the effect of what's happening. That's
I don't want to take up a lot of time, but these other 4 drugs for myotonia that you mentioned, are any of those worth trying?
Oh yeah, Mexiletin, I think is the most commonly used. So if he hasn't tried that, although he probably tried that already, but that's one option.
No, he hasn't tried it. So I will tell him, and he can talk to his neurologist about it.
Yeah, Mexiletin and then lamotrigine. The neurologist is probably more familiar with using lamotrigine because it's a seizure medication, so he could try that too.
And what about the albuterol? Would that help with the myotonia or only help with the potassium?
Yeah, not with the myotonia. It's more
Okay.
for the attack. Yeah,
Okay, thank you very much.
you're welcome.
Thank you for your question. If you want to, the top of the chat is someone asking a question for her husband who has hypokalemia. Did you want to read that and answer?
Yeah, so it says, my husband has hypokalemia. This is from Angie, but with permanent weakness. Now that he is in his 60s, mother, uncle, and aunt were all bedridden from muscle weakness in their 70s. Is there any way to stop or to slow the weakness and maybe gain back what he has lost? There's not a lot of evidence, and this is an area of we need a lot of research. What is the cause of the progressive weakness and periodic paralysis, and what will be the best treatment if we can reverse it? I know there are at least two, these are case reports, maybe a couple of patients, right? These authors reported improvement of what it was supposed to be permanent weakness in patients after I think those patients try Diamox, acetazolamide. So it is possible, at least in some patients, that there may be some improvement. Now, we don't know the cause of this weakness. The hypothesis is that the more attacks you have throughout your life, it accumulates, there's some muscle damage being accumulated there, but that's hypothesis. So my recommendation will be, again, I don't know the history here, but if he hasn't tried, medications to prevent attacks, or carbonic anhydrase inhibitors, acetazolamide or diclofenac, maybe that's an option. And try it, for many months. This has been going on for months or for years of the weakness, then it's going to take months to see an effect. So that would be my recommendation. Next question is, 15-year-old daughter is an athlete, but she has hypo-PP, calcium channel. Her activity keeps paralysis at bay. Did one of your slides suggest that potassium can help to build muscle? Not the potassium itself. This, I think, very similar to the prior question. As for patients that the case reports, again, that have progressive muscle weakness or permanent muscle weakness, quote unquote, a couple of patients improve after starting Diamox or diclofenac and taking it for more than a year. They were taking it continuously. So that's an option to perhaps prevent further damage and permanent muscle weakness down the road.
So if for the next question, if you could possibly answer Yvonne's email that I sent over to you, the one that I sent before we started.
Yeah, let me get out here. If I may. Okay, so where's this one? Okay, so the question was a patient, the patient has hypokalemic periodic paralysis, takes ezetimibe, which is Zetia, 10 milligrams a day, and Praluent to lower cholesterol, LDL. These work well, lowering total cholesterol by 40%, LDL by 51% in 6 months. She's refusing treatment with the statins because heard that statins can cause permanent muscle damage or additional muscle damage. And the question is if I'm aware of any issues with ezetimibe, Praluent, or statins in patients with hypo-PP, or from any research. I can't find any specific research stating that statins or ezetimibe worsens periodic paralysis or weakness. Now, statins can cause muscle weakness and muscle pain, even significant autoimmune response with, I wouldn't say irreversible, very severe muscle necrosis, but that's very rare, usually 2 per million, so that's pretty rare. So the most common side effect, you're going to have any side effect, is going to be muscle pain, which doesn't mean you're going to have the weakness, it's just muscle pain, and then you stop the medication, it will go away. It's not permanent. But, there is always, it's not a 0% risk. If you're concerned and there's already some degree of muscle weakness you're having from periodic paralysis, then probably better to stay away from medications, from the statins if you can, if there's an alternative, because you may be that 1% of 2 in a million that get the autoimmune response and then get severe damage from the statin. So it's hard to predict who's going to have that very rare side effect.
So we have, are there any new drugs in development? Or if you're aware of any new drugs in development?
So the one drug, and I think people still have hopes, is bumetanide, which is a diuretic that inhibits some, transporter in the muscle, on the channels in the muscles, and can be effective in periodic paralysis by changing the potassium equilibrium. The pilot trial I found online was really not successful, but I think they're looking to do a phase 3 trial, but that's still in the works. It had very good results, but in vitro, but also in mice, but not in people yet.
And then is there a doctor in Central Florida that you could recommend who specialize? I know a very good doctor in Central Florida that's at a UF right now.
Well, I think, yeah, Central Florida, North Florida, right? But Central Florida, I don't know, they're talking about Orlando or Tampa, but yeah, I mean, it's a short drive, 2 hours to UF.
Right. So Dr. Chuquilin is not far from Central Florida. So he is definitely a doctor that we would highly recommend that is very familiar with hypo-PP. So we have another question here.
Yeah, it says, I have hyper-PP using acetazolamide for 3.5 years. Initially helped. In the end, it worsened my number of attacks and had 460 attacks last year. Oh my God, that's a lot of attacks. Eventually instructed to come off it by neuro and was recently put on the thiazide, I guess, a water pill probably, and without an attack in 3 weeks. In 3 weeks since starting at 25 milligrams a day. I'm wondering if this can cause worsening over time. Also, because we don't have access to Keveyis in Australia, what other options are there if thiazide stops working for me? What other option I can think of, and this is the thiazide is probably similar to hydrochlorothiazide. So it's a water pill that makes you lose potassium. Well, I don't know. I guess Keveyis is not available in Australia. I didn't know that. Other options will be other water pills that make you lose potassium, right? Furosemide, Lasix will be another one. That's a water pill. It's a very strong one, though. Certainly will lower the potassium. So that would be another option. That's used for swelling or for heart failure. People use it. But it's very strong. So it's stronger than hydrochlorothiazide. And about the question if it will cause worsening over time, I cannot answer that. There are not a lot of studies with hydrochlorothiazide long term, to see what's the outlook in the future. But if you are minimizing, the attacks, you haven't had any attacks, hopefully for a long time. I think the chances of causing permanent weakness are low. Is there any other question? Is Pedro Franco? Is there any medication or treatment or trials in place for treating permanent muscle loss derived from hypo-PP? No, not to my knowledge. I don't think we have anything like that going on right now.
Oh, they gave you a thumbs up on the reacted to, is there a doctor in? And then I'm going to post, Yvonne, I'm going to post the link to our website that does talk more about the pH balance. That's on our website. So that you'll have that information. I'm going to post it in just a few minutes.
Okay, so then I'm going to bypass that question. Then it says, for those of us that have an unknown mutation, any studies or doctors that may be able to find unknown mutations? Well, I know Dr. Cannon to do, a la carte genetic testing, but well, we have panels, right, to find mutations, but if your mutation is not there, and if you have a family history with multiple family members affected, that could make it easier to find a mutation in a new gene, perhaps. So the genes I mentioned here are the most common ones, but the other genes that have been found usually in families, very particular families, some of them affecting even mitochondrial genes. So you will need to have some either mitochondrial testing or something called exome sequencing, in which multiple family members affected and non-affected are tested, and then the abnormal genes that are common to the affected people are studied, and then that's the way we find new genes and new mutations.
Right. And unfortunately, when you go to like the lab companies now, they only do specific ones that your doctors are recommending. And so if you can get a full genome study, and nowadays it's a lot more affordable than it used to be. And when they do find certain things, they can, you can take that to ClinVar, which is the database where you put in, and you may have 25, I mean, I think there's like 20,000 variances or something, but the ones that come up that are like little flagged ones, you can take that to ClinVar and look in, and it has the most current research that's going on that genetic variant. And then if you find something that you think that goes to periodic paralysis, or even not, you can even just send over your report and we can take a look at it. But without a full genome, my mutation would have never been found. So I had to have the full thing done. So it's worth it. We have a hand raised. Let me go ahead and let her in. Let me see. Yep, we can hear you.
Okay. I have a couple questions about diuretics. One kind of went along with what Monica was saying about, sodium helping sometimes. And this is in the case of hyper. Myself and my children find that sodium can be very beneficial, especially with myotonia. And, I find some of using diuretics or sometimes other medications can be sodium wasting. And so I wondered a little bit about how to balance medications that might kind of flush sodium from your body with the need for some sodium if that's something that helps you. And the other part, well, maybe I should just ask that, because the other part of the question is very different.
Oh, okay. So what you're saying is you find that sodium bicarbonate or sodium supplements help prevent the attacks
Of hyper, correct?
Hyper.
But
and particularly myotonia type,
okay. But do
yeah.
you also take a water pill? Diuretic?
Well, yeah, the diuretics.
Okay. Yeah, I mean, yeah, diuretics will drop your potassium mostly. The sodium will, I mean, it'll depend how much a Lasix could drop the sodium, but it'll have to be a lot of Lasix, mostly potassium. Sodium is balanced in different ways. Usually it's retained earlier by the kidneys. So I don't know. I mean, my advice will be if you're worried about losing sodium, then to have your sodium levels checked. If you want to try the water pill, check earlier before taking the water pill, and then once you start the water pill and see if it's actually dropping. My feeling is going to be that it doesn't drop significantly, and you can actually benefit from using the diuretic as well.
Yeah, that's probably true. Most of the time it's been okay. Yeah. The other question was, so myself and my daughter also have idiopathic intracranial hypotension, high internal head pressure. And when we switched from Diamox to Keveyis, the Diamox had it very much under control, but Keveyis, neurologists and pharmacists thought it would be really similar because it's the same drug class, but it really wasn't similar for controlling both, both issues, both periodic paralysis and the IIH. And so we've been, a year and a half adjusting the Keveyis and adjusting diuretics, but it really hasn't helped the intracranial pressure. And so, yeah, I just didn't know if we haven't found anybody that knows more about that. And I keep asking the makers of Keveyis or anyone else, and I guess we just don't know enough about that yet.
So the intracranial pressure is still high. So that's measured with the spinal tap. So they measure with the spinal tap, but it is still high. Is that what you're saying?
No, because we also sometimes get the leaks, so it's not always high.
Oh, okay, but okay. So we're not sure if it's still high though, because the leak can cause low pressure, and low pressure can also cause headache. So if the headaches continue, it may be just that some of it is low pressure headache from too much Diamox or Keveyis activity. So I will recommend either having the eye check, the back of the eye, to look for pressure in the back of the eye, which is a sign of pressure, and also spinal tap to measure the opening pressure. If that's still high, despite Keveyis, then probably go back to Diamox. But I wouldn't know why it is not working, But my impression is that the pressure is going to be normal, and maybe the symptoms are a side effect of the medication, could be, or actually low pressure.
So I have a quick question. I have a quick question on what she was talking. I get the same exact pressure where it feels like my eyeball is going to pop out and fly across the room. And one of the problems I was having with Diamox was it was lowering my CO2, or my what is it? Is it your CO2 that you have? What is it that they do? They check for your pH balance.
Yeah,
is it
bicarb,
CO2?
CO2, yeah, CO2 bicarb, yeah.
It was lowering it so much that it was causing me to have issues in that way. Could it be that possibly that it's lowering hers as well? That maybe if she did something like sodium bicarb to raise it, that she might be able to balance out a little bit with it? Or is that risky?
Acidosis, because Diamox and Keveyis, they can cause acidosis. So that's something to keep an eye on as well, especially in high doses. Perhaps that can cause headaches too, sure. But low pressure, just when we use it in people with intracranial hypertension, sometimes they go the other way, and they develop hypotension, and that can cause headaches.
Oh my goodness. Okay. So it's always going to be complicated with all of us, right? Unfortunately, right? Okay. So we're slightly past our time, but I want to try to get a few more of these questions in. So the one here from Rachel, what's the general process to start someone on a potassium sparing diuretic if they're already on a relatively high dose of potassium chloride? Would you decrease the potassium while adding the diuretic?
So I would measure the potassium and see, they're already taking a lot of potassium. We'll measure the potassium to see how high it is without a diuretic. And then if it's not high, if it's 4 or less than 4.5, then yeah, we'll start the diuretic and then perhaps follow it, every 1 or 2 weeks, follow the potassium until you get a good dose. But if it's already on the high level, even with the oral supplements, then I will be more careful, probably monitor more frequently, every 2 or 3 days until you get a good dose. And also check an EKG at baseline.
So we have, I'm sorry.
Yeah. And then you want me to try to answer the rest, or how do I do?
I think we have just a few more. Yeah, if we could do Paula and then just work down a little bit, and we'll try to finish out the questions that we have. And I did post the link to the pH information that's on the website.
So for hyperkalemic, is there a test that we can use at home to see what our potassium level is? Monica will know more, actually. I don't know. Is there? I don't think so. I mean, I don't know.
So to give you all a little preview of one of the presentations that Dr. Cannon is going to be doing at this year's conference, he's actually going to be talking about potassium and how it's not as important to, as we all have, what we've all been taught for so many years. It's not as important. And because the blood can be, which we all know, the blood can be very misleading. And it all has to do with what you touched on today, though, too, Dr. Chuquil, where we have the potassium, especially for hypos, it's there. It's just in the wrong place. So a monitoring it at home, instead of monitoring, feeling what you're feeling, usually how you feel is a better indicator than actually having a monitor that's telling you, okay, it's normal today. Well, I don't feel normal today, or it's low today, but I feel good. It's one of those things where it gets very complicated. So he is going to talk at length about that at the conference. But no, I am not aware of anyone that is easy to use and is not $10,000, because there are some that are somewhat easier to use, but they're like $10,000. So Allison, did you want to read Allison's question and go ahead and answer?
Yeah, I have says I have a problem with severe lactic acid buildup as well as hypo-PP. I require 1 liter normal saline to keep lactic acid under control. You mentioned avoiding saline for IV infusions. What would be a better option? Any idea if the lactic acidosis could be related to hypo-PP? Well, I'm not aware of the regular hypo-PP being related to lactic acidosis, no. But like I mentioned, there are other genes involved in periodic paralysis. There is one, maybe a couple of families, I think, that were reported to have mitochondrial gene mutations that were also presented with periodic paralysis, and along with other conditions related to mitochondrial disease, like some of them have hearing problems, motor problems. But there could be a variability of presentations in mitochondrial problems. Mitochondrial problems are known to cause lactic acidosis, so that could be related, perhaps looking into that option, or perhaps new genes affected. The other, if you don't have genetically proven periodic paralysis, maybe a kidney problem or some other medical problem causing hypokalemia, so low potassium levels may be actually the cause. Maybe it's not the typical hypo-PP. So that will be another option. Perhaps talking to a nephrologist, a kidney doctor may help at least to start. Tyla, I have suspected hyper-PP. I found oral salbutamol every 3 hours plus Diamox can control full body paralysis episodes going from 2 to 3 attacks per day to none. However, the Diamox loses effect after 4 weeks. Every time I've been trialing a 2-week break, then going back on Diamox, and this seems to be enough time for the medication to work again. I was wondering why. Well, depending on the dose, I don't know the dose. If it's a moderate dose, perhaps body, obviously everything you can get used to that small dose, and perhaps increasing the dose will be helpful. The other option I would suggest is trying one of the other water pills, hydrochlorothiazide during the break, and that way you are completely sure that after 4 weeks you lose effect. So you try Diamox 4 weeks, and then the other water pill for these 2 or 4 weeks, and then you go back to the Diamox and you go like that. And the idea is just to minimize or prevent all the attacks, right? That's the goal at the end. Next one, any relation with mitochondrial damage and treatment? Not directly, but like I mentioned, there is at least one gene that's a mitochondrial gene mutation, DNA gene mutation that has been associated with periodic paralysis episodes. So not directly, but some families have that gene mutation. Next one, currently finding that reducing my body voltage caused by EMF through the use of earthing grounding reduce the frequency and severity of my attacks. And you're aware of any studies of EMF on voltage-gated channels? No. EMF must be, I don't even know, extra I don't know what EMF is. Frequency. I don't know. Next one, are there any medical devices to determine potassium levels? Okay, this is the same. Whole genome sequencing, okay. $400. They have specials. No, really? Okay. Wow, that's cheap. I think it's more expensive than that, but just be careful where you do it, I guess.
But I think that the cheaper ones, you have to calibrate them like every time you use them. And so that's one of the things that we hear is challenging from patients. But before we go, because we are past our time, Sienna has quite a few questions that has come in through our Instagram that we wanted to answer.
Right.
So Sienna, let me ask to unmute you.
Hi.
Hi.
So we have several questions from Instagram, as Monica said. The first one is, what type of potassium-sparing diuretic works best for most patients? Hypo.
Eplerenone would be my recommendation. Yeah, because
The next question,
less side
yeah,
effects.
that answers the question. The next is, do we know why Diamox is effective for hyperkalemic periodic paralysis?
Again, it's the same. It's supposedly the same mechanism as hypo-PP, changes in the pH. That would be the hypothesis, change in the pH. It's more as acidosis, but the final mechanism is unknown, really.
That makes sense. Is it common for Diamox's effectiveness to wane quickly?
That actually wasn't, well, there haven't been any Diamox trials, but in the Kebeyes trial, the effect didn't wane, and the same mechanism. So I think that's uncommon. That's uncommon.
What type of improvements can you expect to see with a med like Diamox?
What type of improvement is that what you're saying?
Yeah.
Improvement in, well, the goal of the treatment when you use Diamox is to prevent the attacks of periodic paralysis. And in some patients, like I say, case reports, they have reported improvement in the weakness that they have, the permanent weakness. But that's very, very few reports, okay?
Is there any medication out there that can help kids with periodic paralysis? This person's oldest is 19 and their youngest is 12.
Yeah, I mean, Diamox and Kebeyes have been used in trials in adolescent people and children. So under supervision, they can be used. Those would be the medications to recommend. And then the oral potassium supplements, obviously.
Thanks. That's all of our Instagram questions.
And then the only other questions, we're getting quite a few questions about the medical devices for the potassium levels. I just want to, I'm not sure when those came in, but I just want to, let everyone know that, at this time, there's nothing that we recommend from the Periodic Paralysis Association. Like I was saying, the different, it has to do with, a lot of them have to do with calibrating the device. And if you do not calibrate it correctly every time, some of them are every time, some of them I guess are not as often, but if you don't calibrate it perfectly, then you're not going to get an accurate reading. And also, this is something that we will be discussing in much more detail, and specifically potassium levels and reading them, not only at home, if that's what you choose to do, but also when your doctor in your doctor's office. We touched a little bit about this on the documentary as well, where it's such a gray area. You can be symptomatic, you can be in a full episode, and your potassium levels will still read normal. And that's one of the things that Dr. Cannon really wants to talk about, because if we're focusing on it as patients and we're taking potassium, even though we may feel fine, but we're reading on our home meters that our potassium is low, that may not be the answer either. So if we can shelf the potassium topic just a few more months. And again, I'm going to give you guys a little bit of some information. We will be holding our periodic paralysis conference. We haven't announced it yet, but we will be holding it in Orlando at Shingle Creek Labor Day weekend. So those announcements will be coming out soon. But that is a topic that we are fully aware is a very important topic to patients. And that is why Dr. Cannon is going to do a whole presentation specifically on potassiums and measuring potassium, and how important it is, or, where it weighs. All right. The EMEF is an electromagnetic field from Wi-Fi and all the electric surrounding us. So we can, if we want to go back to that one question from Mark.
Yes, the question was if there's any study or anyone studying the effects of EMF on voltage gated channels. Not I'm aware of, but I'm not that familiar with that.
No, and one of the things, I don't believe so either. I know that in past conferences, there was some concerns about certain electronic waves and fluorescent lighting. And there is nothing that we have, there's nothing that Dr. Cannon has that any research or anything has been done on people who feel that affects them negatively. And we can do one more question. We have one more from Paul, and then we'll cut you loose because I know he kind of held you back. I want to get you home and have dinner. So one more question, please.
Where is it?
It's the last one from Paul. We are hyper and we need to monitor our levels.
Oh, I don't see that. I don't see that here. Where is it? Can you read it then?
Yes, it says we are hyper and we need to monitor our levels. We do not know where we are at on daily basis, but we are an old family that had many years. We knew what we had hyperkalemic. Anderson clan, feel free to contact me. So I guess that I'm not sure if they're saying that they figured out a way to do it easier with a monitor.
Maybe.
Maybe. Yeah, the only feedback that we get is from patients that have monitors. And what we have heard is they're either extremely expensive or they're the ones that you purchase that you have to calibrate every time you use. And so it's very frustrating because if you can't afford the more expensive ones, you're using ones that you have to calibrate every time you use it. So, all right. Well, thank you all so much. Thank you, Dr. Chuquilin. It's always a pleasure. It's always a pleasure. And again, this has been recorded. It will live on our YouTube channel. Once it is posted, we will announce it, and it will be added to our website as well. So it usually takes about a week or two to get it all up and everything. So if everyone could be patient, but we will have this information up. And everyone is saying thank you so much. So thank you all so much for joining us tonight.
Thank you. Have a nice night. Nice evening.
Have a nice night. Bye-bye.